Hello everyone, welcome to my presentation on documentation skills. This presentation is mostly grounded in curated information about ethical and legal requirements for documentation, from trainings and resources from mental health professionals, as well as my own experience. However, please note that there is no clear, correct, or guided right way. The goal here is really to provide you with higher quality documentation. This presentation really is for any therapist in any stage of their career. I encourage you to use what you learn in this presentation as guidance for how you think about your documentation. I must say that you are to always follow the directions from your supervisors and any legal directives. The suggestions in this presentation for documentation really is only as good as your clinical judgment. You really must reflect on what applies to your work. I understand that some of you who are viewing this presentation may work in agencies or organizations that have policies and procedures or processes for documentation that may limit some things. However, you can still develop your own style in writing. This presentation will cover the reasons therapists are to document, what is to be documented, trauma-informed documentation, cultural awareness in documenting, further writing tips that support documenting, and what does not belong in documentation. I want to note that I will not be talking about AI in documentation. In terms of AI, I recommend that you refer to your licensing body and further reflect on ethics and standards of practice, and more so your workplace policies and processes. I want to take a second and introduce myself. So my name is Stephanie Fuller. I am a registered psychotherapist practicing in Ontario, Canada. I am registered with the College of Registered Psychotherapists of Ontario. I am further trained in and have experience in supervision and consultation. This often includes supporting high quality documentation for supervisees or those that I consult with. I also have experience in community, nonprofit mental health, post-secondary education, and private practice providing psychotherapy. Within those roles, I've provided services in various settings to a range of clients with diverse needs, from children to adult, such as in first responder locations, retreats in the community, in schools, and of course in office and virtually, to individuals, families, and groups. Therefore, having had to document various situations. Okay, so as we move through our objectives, what are some of the reasons we document? Well, one, it is a legal requirement. In Ontario, therapists are subject to the Personal Health Information Protection Act of 2004, PHIPA. It is important to review federal legislation as well, which in Canada is subject to the Personal Information Protection and Electronic Documents Act, PIPEDA. So please research this in your provincial and federal area further. Number 2, it is an ethical obligation set forth by standards of practice and regulatory bodies in Ontario. So in Ontario, this is CRPO, the College of Registered Psychotherapists of Ontario, or OCSW, SSW, the Ontario College of Social Workers, Social Service Workers. Number 3, documentation can be used as a tool to promote client care through reflection and planning. As mentioned above, Again, you are adhering to your regulatory body standards of practice. There's a concept called beneficence. This concept is acting in the best interest of your client. Really, it is doing no harm. This concept reminds us that documentation is meant to help us serve our clients. Lastly, documentation is really our evidence in any investigation, which can include with licensing or in court. Now we will move into the next objective. So this is what to document, and this starts with consent. So we want to document relevant observations about the client's capacity to provide consent. This means, are they able to understand the treatment, why it's being recommended, and what will happen if they accept or refuse treatment? So really this is reflected in their understanding of the consent process. So the risks and benefits, the client's rights and responsibilities, and this really should just be in your consent form and that process of going through that. So if anyone is found to be incapable of making a treatment decision, then of course the substitute decision maker is asked to consent, so all that should be documented. Further, in this process of consent, any questions or concerns clients have about consent will be documented, and which aspects have been consented to and refused need to be documented. It is important to remember that consent is an ongoing process. There will be instances in the therapeutic process where it may be necessary or advisable to seek or reaffirm a client's consent. This can include when there's changes to the therapeutic plan, such as, a different treatment approach could be more beneficial, or where the therapeutic goals are being revised. So we want to document the reviewing of consent, and also with that, I want to note that we are always dating the documentation of consent. I have been taught personally that consent, if able, should be in written format, but also remembering that a signature of a client is only partial evidence that they have provided informed consent. A conversation is always important with that, and a documentation of that conversation will be helpful as well. Speaking to the topic of consent, I want to spend a minute talking about releasing and the request of information and the consent related to that, and how we document this process. So in terms of documentation, you're documenting who you're disclosing to, what you are disclosing, and really that's only relevant information to the current discussion or situation, and why you are disclosing, so the purpose or the rationale, and vice versa. So if someone has, a professional has information about the client for you, you want to document the informed consent process of this with the client, such as the risks and benefits, the reviewing of the potential information that's being requested or that you're suggesting to release, the rationale why, and the options of responses to any requests for that information. Any legal exceptions that may apply to requests, and if the client is the one requesting their own file or portions of their file, and there is a serious risk of harm for the client to have access to that, if you are declining that, you need to document the rationale why. We're also documenting any client declines for requests from information from any third parties, or if we suggest any any sharing of information by releasing information, and the client declines, we are also documenting that as well. In terms of what to document for client information, you want to document the client's full name and preferred name, current address, and home address. And I put that because in my own work, I have had clients that go away for school, college, university, and visit home during like holidays or breaks. And this is especially important if you're providing virtual counseling and there's a high-risk situation. You want to know what location they are at and have those locations handy for if safety planning is needed or an intervention regarding high-risk concerns is needed. So you also want to have the client's telephone number, the emergency contact on file, again, for safety planning reasons. So the emergency contact's relationship to the client and their phone number. You can have a point of contact person on file. This can be a caregiver. This can be for many reasons, such as a booking purpose if you're working with younger individuals. It can also be for payment purposes, things like that. The date of birth and the unique identifier number. In continuing with what to document for client information, you want to document relevant information regarding the client's legally authorized representatives. You want to document the full name and contact information of any professional who referred the client, along with the reason for the referral. If the client was self-referred, this should also be noted. I do want to say that agencies and organizations may have like referral or intake packages or processes where referring agencies, organizations, or clients can speak to this. In private practice, you can make your own intake form where this can be spoken to from other clinicians or health professionals or clients. I wrote here safety notices. These can also be referred to as like alerts, or there's other terms, but for the sake of this presentation, I wrote safety notices. And really this includes individuals or clients who have reported some sort of harm, whether it's in relation to themselves or others, that really could happen during kind of your services with them, and that documentation should happen. So I think of some examples to provide clarity around what I'm trying to speak to here. So when I write this, I think of instances of abuse and things that are in place, like restraining orders or no contact orders. So for further example, I think of if you're working with a minor and people come and pick them up from the session, you may have a safety notice in the file of someone that has a no contact with this client, so that you are making sure that when they are receiving services from you, that the person that's picking them up isn't that person that has a no contact. So that could be one example. Another one is if there is something legal in place between your client and another client, you want to make sure that that's noted somewhere, because you don't want to actually schedule that other person as a client too and have them end up in the same waiting room or crossing paths in your office. So that's important to document. Again, I would just want to set a reminder out there that it's crucial to keep all client information up to date. This is important for safety reasons. It's just important in general. I want to speak to other important factors to document. You want to document who is paying for the sessions and if that's been consented to, because they'll need to know certain things like the scheduling, the no-shows, the cancellations, especially if there's a fee associated to that. Document the direct billing or not in the conversations around that, as information will be shared with insurance companies around date, time, frequency, pieces like that. In terms of transportation, this can include caregivers for clients or peers for clients or anything like that. They may gain access to scheduling. Clients may consent to that. So again, that conversation on informed consent. Financial records, there is a documentation process to that. It can be separate from the clinical record, but that is also documented. Therapist contingency plan, so if there is any reason that you abruptly cannot work with your client anymore, there needs to be a documentation of that of a conversation prior to engaging in services, what that plan looks like for your client in the file. We also need to document any assessments done. So assessments are any therapeutic assessment, including methods, the results of, the conclusions, the problem formulation from the assessment, or other professional opinions. The type of assessments commonly used is the PHQ-9, the GAD-7, anything like that. We are now going to talk about how to document risk assessments. If something is not documented, and this includes risk assessments and further safety planning, it's going to be assumed that it was not done in session. If in fact you did not risk assess in session, you need to document that in your note and the rationale as to why you did not risk assess. In your session, if there is any risk identified or determined throughout your session, you will want to assess for that level of risk and intervene if necessary. So whether you use an informal or formal assessment to come to your conclusion of that level of risk, that will need to be documented. So I know some agencies and organizations may have a certain practice where you use a formal assessment, maybe the Columbia Suicide Severity Rating Scale, or just through informal conversation. However you risk assess, that needs to be documented. And then the intervention, whether that's a safety plan or contacting authorities, that needs to be documented. I know again that some organizations, agencies have a more formal safety plan document. You also, if you're a private practice, can create one of those yourself. That is an option. If you inquire about risk, your session note should always indicate that you did and what the client's response to that was. I think of the example, the client denied suicidal ideation at this time. You can include direct quotes from the client. It can sound anything like, "I'm not going to do anything to hurt myself. I just wish I did not wake up." You want to document the presence or absence of a plan, their access to means or method identified in that plan, and their intent. So an example may be a client. The client is, although the client reported recurrent suicidal ideations and wishes to die, they did not have a specific plan and stated, quote, "I'm not going to do it." You want to document the therapist's response to the level of identified risk, the actions taken, and the plan that the therapist has come up with. So I think of an example, the client stated a desire to kill his wife, has been thinking about using his handgun to do so, and recently purchased ammunition. So given the level of risk, I, being the therapist, consulted with a clinical supervisor, and you would state the name. We called 911 immediately, and ... So that would be an example of that point. You also want to document and file risk and safety planning immediately. If a serious incident happens, which could be a suicide or a homicide related to your client, you do not want to enter any time and date stamped session notes after the fact. In general, I want to remind you that when working with high-risk clients, you are not delaying any documentation to be in a position where there's outstanding notes after the fact of a serious incident. You can, however, write a note summarizing a briefing with your supervisor. Okay, so another thing you want to document is the client's goals. What are their goals for coming to therapy, right? I have learned over time in my own work that goals are often better if they are positively framed. So, for example, to gain rather than to reduce. And I find this because clients are more motivated to work towards them when they're positively framed. That's just in my own experience. Goals should be accompanied with an assessment tool, like we talked about in the previous slides. You want to use evidence-based modalities to work towards these goals. And again, the clients are informed of these evidence-based modalities. They are oriented towards them, and you want to document that. And you want to use SMART goals. So again, SMART stands for specific, measurable, attainable, realistic, and time-bound. So an example of a general goal that's not a SMART goal and meeting this criteria that I've outlined here is client will increase management of ADHD symptoms. Whereas a SMART goal will be client will use ADHD management strategies at least twice a day using behavior tracking and mindfulness. Now we move into what to document for session notes. These may also be called charts, process notes, case notes, whatever your preference is or where you work and what they refer them to. You will always want to document the client's name, the unique identifier. Sometimes you may be working with an EMR system. Some common ones are Jane in private practice, Owl in private practice. You might be using one with where you work, and they will generate a unique identifier number for you. The date and time of session, the length of session. So I know it might be 60 minutes, right? The type of session, such as if this is the initial session, a follow-up, a group therapy session, a family session, couple session, or even if this was virtual, in person, or a phone session. If there's other attendees, you will also want to document the content, such as the themes or the issues that are being discussed during the session, any significant statements made by the client that reflect their feelings, their symptoms, or their progress, and what the client discussed related to their goals, like we talked about in the last slide, or their treatment. It can be helpful to reflect on these following questions when trying to figure out what to document in terms of the content. The first is this information clinically relevant? Is this information clinically relevant for my ongoing work with this client? Would this information be important for another professional if they needed to treat this client? Is this information based on a fact or a judgment? So again, reiterating that we want to document specific goals that are addressed as therapeutic goals and improvement towards. We want to document the interventions used and the client's response to and any progress towards those goals with those interventions. Documenting interventions is the cornerstone of professional, effective, and ethical therapy. We want to outline any plans or objectives for the next session. This could include areas to explore or specific interventions to employ, and we really want to have a rationale if there is no next session. We also want to document in between assignments, both for ourselves as the therapists and the clients. I also want to express how important it is to document service interruptions. This includes no-shows and cancellations, right? This speaks to a pattern. It also may speak to later termination or discharge or closing the file. You want to document any potential ethical dilemma or high-risk scenario with more detail. Sometimes therapists find themselves avoiding writing the session note. You want to document any session note because it's better than no note at all. I read this phrase, and I want you to keep it in mind, that a note that is a C+ is worth more than no note at all. Therapist's signature and a date is needed for every session note. We are providing reasoning for an amendment and signing and dating that amendment to a note. And those reasons for amending the note could be missing information, inaccurate information. I've heard others suggest, and I've read that others have done this or suggested this, that in documentation of session notes, they could do several levels of collaboration with the client in making session notes. Some are that they'll review the session note at the end of the session with the client. They input information kind of during the session, and they review it with the client at the end for collaborative process. Sometimes they write it together at the end of the session, pieces like that. Those are things that you can consider. For those of you that provide partner or family therapy, you can have one file if it always is the same combination of people. When the partner or family attend in different combinations, you want to keep separate files. The same thing applies for group therapy. You want to keep separate session notes for individuals receiving family, group, or partner counseling, especially when there's an unusual event that affects an individual client. When an ethical dilemma occurs, you want to document the situation, the factors, and the safety concerns. You want to document anyone you consulted with and why, whether it's legal or anyone who has expertise. You want to document the considerations for actions, whether it's ethics, employer directives, things like that. You want to document specific actions taken, and again, the rationales. Again, employer directives, ethics. And then you want to document the relevant follow-up with the client and or others. Sometimes there will be guests or collaterals that can be requested to attend sessions. What do we document in terms of that? So you want to document setting clear boundaries by clarifying certain things. So when you want to document the number of sessions that a guest may attend, and also having a referral plan in case this guest needs or asks for services themselves. You want to document the client consenting to any communication with this guest outside of session. So if the guest reaches out by email or phone, you also want to document the relationship of the guest to the client and the reason the guest is attending the sessions. So this would also include clarifying and documenting the service provided and who the client is. This goes with defining the role and expectations of the guest during the session. So, for example, if the guest is a parent or a sibling or a caregiver, we're going to be clear that the session is not family therapy. Considering what to do if the guest requests a copy of the records for that session or sessions. So really you want to have a discussion on confidentiality and the limits for the collaterals. So you want to review things like the Personal Health Information Protection Act of 2004, so PHIPA. Some choose to actually make a collateral agreement form outlining all of this and then have the collateral guest sign this. Just as a process. When there's an interpreter, you want to document that the role is clarified with the interpreter. You want to review the confidentiality that is to be maintained of the client with the interpreter. You want to document the informed consent process of the use of an interpreter, including reviewing the risks and benefits and limitations of communicating via an interpreter with the client. You want to document the name of the interpreter, and document if the interpreter is being used in person, telephonic, or in video conferencing. Okay, moving into treatment plans and what to document. So sometimes when you work for an organization or an agency, you may have timelines when you do treatment plans. It may be a formalized document. It may not be. Sometimes you can find templates on documents for treatment plans. So if the plan towards the therapeutic goals change, you're going to provide updated documentation and the rationale of what's going to change in terms of your treatment plan for this client. And it's normal for plans to change over time. If there's no change to the plan, you're going to document no change in the rationale. So you may write something like continue to, and then the rationale. Remember FIDO, F-I-D-O, when documenting symptoms. FIDO stands for frequency, intensity, duration, and onset. Symptom change is really the primary indicator of a change for treatment plans, and really therapy effectiveness. Client responses and feedback are also important to document. So the client's responses to interventions will also be helpful in terms of how they are moving towards their goals. And these can also be part of the rationale for if there's a change or we're keeping the same in terms of our treatment planning. And we want to avoid the use of non-collaborative language when we're talking about treatment planning. So an example of non-collaborative language is client needs to try harder to implement strategies, right? Whereas more collaborative language could be something like client has not followed through with the recommendations. So you can really document treatment plans in a session note in your own template or one that's provided to you. So continuing on, you want to document progress. I was once told that if your file was reviewed and there was no documentation of improvements, it would be seen as you were keeping the client in therapy and it was not working, and that this could be seen as harmful, right? Lack of progress is also important as it's going to show the reasoning for continuing the treatment. However, we want to show that there's going to be treatment planning that shows that we're also going to try something different. We want to reflect on the client's strengths and supportive factors. We also want to document adding additional services to a client's treatment and the rationale. Adding treatment can include referring them to another service, whether it's internal or external, if we're working at an agency or a group practice. For example, group therapy. In making changes to the treatment, there needs to be consent, and again, that's documented, and again, the rationale for why we are adding that service or making that change. Okay, mandatory reporting. We want to document the date and time of the session when the disclosure was made. We want to do our best to document the client's disclosure verbatim. Document any immediate actions taken in response to the disclosure. Document the risk assessment and safety planning that was done based on that disclosure. Document the process of reporting the disclosure, including the date and time of the reporting, the method to communicate the report, the name and title of the person and the agency that you reported to. For instance, with police, I personally always get the name, the badge number, and if there is an incident number, and I document that. You're going to document your follow-up plan with the client, which will likely include ongoing risk assessment and safety planning, and any other reporting directions from the authorities. We are also documenting points of contact. Some may refer to this as case management, correspondence. These are all consented to out-of-session contacts with the client's authorized representative or any other consented to person from the client, like collaterals or guests. These include, however not limited to, letters, emails, text, phone calls. These can include copies of written communications, documents, or forms. When any major unexpected negative outcome occurs during your session or on-site for your services, you want to document the incident. You also want to document any action taken and follow-up. These can include, however, are not limited to injuries to the client, damages to the property, breaches and misconduct, anything health and safety, anything medical. With consultations, we want to document informing clients that we are involved in consultations. For example, we want to inform them in our consent form that we participate in consultations, whether it's peer consults or anything like that. If we know we're going to consult on something, it's best to inform that client in that session and then document that with that session note. We want to document the date and relevant details of every internal and external consultation received from or provided to another regarding the client. Remember that we need to have consent to release or request information and document consent if using the identifying information of a client in a consultation. To kind of err, if you are wondering if you need to document a consultation in a client file, you want to document consults related to if the consult was due to a client need, a specific issue related to the clinician in the case, and if the consultation will impact treatment decisions for this client. It is always best to plan that you're going to document a consult. In terms of closing a service, you want to document why it ended and how services will continue if needed. You also want to document outcomes attained. You want to document referrals or any follow-up recommendations. This information is important to document because It's important to third parties, especially for continuity of care or in the event that the client does return. When making referrals, we want to document the rationale for the referral and to whom the referral is being made. We want to document the informed consent to refer, even document if it's internal or external, document any decline of a referral, and we're documenting any disclosure related to self-referrals or requests for services internally or for clients' information to request external referrals. We are also documenting disclosures to clients of any perceived conflicts of interest in referrals to them. When we are self-referring, we are documenting that and the 2 other referrals provided with the discussion that we had on reassurance to the client that the existing relationship will not be affected. Okay, so cultural awareness in documenting. It is important to provide culturally competent care to ensure that therapy is respectful and effective for clients from diverse backgrounds. There is a need for cultural considerations in all forms of documentation. We start with client information, so the cultural background and cultural history of the client. This can start at the intake process. You can have it built into your intake forms. So again, this includes, however, is not limited to ethnicity, race, nationality, religion, language, sexual orientation, gender identity, immigration status, and any other relevant cultural identifiers. We want to have cultural considerations in our session notes. This would also include with the goals for therapy, also in treatment reviews and our plans for treatment. So we really want to, within those, have cultural considerations with our reporting of symptoms and how culture influences this. We also want to talk about how cultural values and beliefs influence mental health and treatment. So, for example, a client expressed concern that their family's stigma about therapy might affect their participation. We also want to document cultural awareness in the goals influenced by culture. So that might be, a client, for example, expressed the client's goal is to balance her individual mental health needs with her family obligations based on their culture. We also want to be culturally aware in other forms of documentation. So that might be consultations with someone who's an expert in our client's culture. In terms of treatment planning, right? If we're making adjustments to therapy, for example, if we're adjusting to more narrative therapy techniques because that resonates more with the client's storytelling tradition in their culture. We also want to note cultural awareness in resourcing with clients, such as in safety planning, or again, in treatment planning, such as with cultural strengths. That can be seen as protective factors. Continuing with cultural awareness and documentation. In all documentation, again, you want to avoid stereotypes, assumptions, inappropriate language. We want to use first person language, person with a disability, not disabled person. In referrals, we want to refer to an appropriate cultural care if needed. We want to work to identify treatment barriers, such as if there's therapy in another language to be provided, right? We want to document those barriers to treatment and the strategies we use to address them. So, for example, a client mentioned language is a barrier, and we facilitated a discussion on how to resolve this. We want to also make sure that we are using trauma-informed documenting. So do not use unnecessary violent language in your documentation. So often verbs convey violence in contexts that do not require it. So an example you think of is taking a stab at it. This is to mean that we will give something a try. In therapy, this kind of wording is not necessary. Do not use objectifying language. Objectifying language can bring up feelings of past experiences of abuse, marginalization, and oppression. Using non-objectifying language is a necessary part of trauma-informed documentation, especially if we are being trauma-informed therapists and client files may be viewed. Do not use judgmental language. Often we describe someone's choices and actions, and how we do that can reflect judgment. Your documentation should show respect for your client's decisions, as well as an awareness that the possibility of trauma might have impacted those decisions. Do not generalize in your documentation. Just because one survivor of abuse has used a substance to cope does not mean all do. Your documentation should reflect an understanding of this. Do not patronize. Patronizing can take, for example, the form of euphemisms in your documentation. And do not blame. Okay, so I created kind of some general documentation tips that others have recommended and provided over time. So the first one is be clear, concise, and comprehensive. Use accessible language, so avoid jargon, psychological babble. That's what some would refer it to. If such a term is needed, explain it. Be objective. Focus on observable behavior. Use direct quotes rather than personal opinions and interpretations. Be consistent, so maybe adopt a consistent format for your notes. Make it easier to find information and track progress over time. When things are consistent, it's just easier that way. This might involve like a standardized layout, standardized headings. It's just easy. You want to document any boundary setting with clients. You can use bullet points too. I find it just helps. It's more consistent. Continuing with documentation tips, always assume your clients, the courts, or the licensing will see the documentation. This keeps us accountable in our writing. This makes it much easier to stay fact-based and objective when we're assuming that someone else is going to read our notes rather than hoping that they never will, right? Avoid emotional documentation. So really, to do this, you need to pause before you document. Check in with how you're feeling. Notice any tension or anxiety before documenting. Maybe use some mindfulness, practice some gratitude. Use correct grammar and punctuation. Depending on use of grammar, several distinct meanings can be made from the same statement. So you can see here I have let's eat mom versus let's eat mom, right? Avoid ambiguous abbreviations and define abbreviations. So sometimes we see N.A. in spaces. N.A. sure can mean not applicable or Narcotics Anonymous. Right? We're in a certain field here. So Define the abbreviation. Spell it out. If you don't just assume people know what it means. So spell it out once and then use it further. You can continue to use the abbreviation down. Do not use blank space. It can be tampered with. Avoid cutting and pasting. I've seen way too many errors when people just cut and paste, even from prior session note to the next session note, or if they use something similar with another client. Just too many errors and possibilities there that can happen. We have talked a lot about what to document pertaining to the client's file. I want to spend some time briefly talking about what not to document in the client's file. So I start with rough notes, developmental notes. There's a lot of names for what this note might be called. These are just two names that I've heard of. So these notes are drafts of really the therapist's impressions, maybe reminders, personal reflections. They are not notes that are hiding relevant clinical information, and they do not replace session notes. They may be notes about the therapist's own processes that could be used in clinical supervision, and they do not identify the client. Supervision notes are kept separate from the clinical file, and any therapist or staff personal challenges are not documented in the clinical file. I imagine that there are specific questions that you have or scenarios about documentation. I know that we weren't able to cover everything and go through all the examples. I do want to let you know that I specifically offer consultation and mentoring services that can be around documentation. I've left my website there. I did reference templates today, and a lot of the information I did discuss today has come from this resource. It's a book by an individual named Melissa McCaffrey, and this person's book is called Stress-Free Documentation for Mental Health Therapists, The Complete Guide to Progress Notes and Treatment Planning and Medical Necessity. So you can find a lot of what I discussed today and referred to in terms of templates from that book. I also do want to remind you that this does not replace your regulatory body's information on documentation or any legal advice that you hear or are directed. Here's a list of my references that guided me through learning a lot about documentation, and that also lended to my presentation. Please feel free to look through them and also use them to guide your learning as well. And again, more of those references here. I want to thank you for taking the time to watch this presentation on documentation, and I hope that you have gained some takeaways that help you reflect on your documentation and improve your documentation skills.